Hello, my name is Dr. Robert Dunn. I'm the Chief Scientific Officer at Clinilabs Drug Development Corporation, and today we are having a Clinilabs Fireside chat with Dr. Rashmi Patel. Welcome, Dr. Patel.
Well, thank you. It's a great pleasure to be joining you for this fireside chat on schizophrenia. I'm Dr. Rashmi Patel. I am a senior clinical lecturer at the Institute of Psychiatry, Psychology and Neuroscience at King's College London here in the UK, and also a board-certified psychiatrist. And I specialize in the investigation of clinical outcomes in mental disorders using real-world data, large-scale data sets, including in people with schizophrenia.
In today's fireside chat, we will be discussing schizophrenia. I thought we could start our conversation by discussing some symptoms people might know are part of schizophrenia, including positive symptoms, as well as other symptoms that are not as widely known. Dr. Patel, could you describe what the positive symptoms are for schizophrenia and explain how they affect individuals living with this disorder?
Of course, yes. So, in terms of the positive symptoms related to schizophrenia, broadly speaking, we could classify these as related to disorders or symptoms affecting thought or perception. So that someone might be experiencing unusual thoughts, which could turn into fixed beliefs, delusions. They could be persecutory delusions, grandiose delusions. And these are thoughts which are not based in reality, that there's something that someone believes, but there's no real evidence for it. And then in terms of perceptions, these would be hallucinations. So, for example, auditory hallucinations, hearing voices. Occasionally, an individual with schizophrenia might have other types of hallucinations, for example, affecting vision or other senses. And in terms of the thoughts, as well as disordered thought content, an individual with schizophrenia might have disordered thought form. So they might have thought disorder, difficulty forming coherent sentences if they're in conversation. The positive symptoms may also include hyperarousal or hostility. And sometimes someone with schizophrenia may not have insight into the nature of their symptoms and may not be aware that they may be unwell. So altogether, these are some examples of some of the positive symptoms.
Thanks, Dr. Patel. Some of the other symptoms that are less well known include symptoms where the subject has behaviors that are in the negative compared to healthy controls. Could you describe some of those negative symptoms for us?
Yes. Yeah. Well, negative symptoms are a really important feature of schizophrenia and something which only more recently we've been paying attention to. And in actual fact, they really are a core symptom of schizophrenia, affecting most patients. And broadly speaking, negative symptoms can be broken down into two types, either experiential negative symptoms or negative symptoms that affect emotional expression. So what do we mean by experiential? Well, these are negative symptoms that essentially affect someone's experience in terms of how they interact with the world around them. An individual with schizophrenia might experience social withdrawal. They might spend less time with their friends and family, emotional withdrawal. They may have poor motivation, which makes it difficult for them to perform their daily activities. They may experience anhedonia. That means a decreased experience of pleasure. And sometimes these symptoms may affect an individual's ability to care for themselves in terms of grooming and hygiene. In terms of the emotional expression, an individual may experience blunted or flattened affect, and that essentially relates to someone's emotional reaction. And in normal conversation, for example, your emotional reaction may change depending on what you're discussing, the emotional content. Well, that may not be the case for someone with schizophrenia. They may have quite a flattened affect or blunted and may not react so much emotionally. They may not make good eye contact and their speech may be minimal. The tone of the speech might be quite flat and monotonous. And when they're speaking, there may be some delays or increased latency of speech. So these are some examples of negative symptoms. And actually, although sometimes the positive symptoms may be initially the most disruptive, it's actually the negative symptoms which can have a tremendous impact on functioning and quality of life.
Now, how about cognitive symptoms? There was a neurologist and psychologist in the 19th century named Emil Kraepelin who termed schizophrenia as dementia precox. In other words, translated as premature dementia, because of the profound cognitive effects in schizophrenia. Maybe you could talk about the cognitive impairments in schizophrenia.
Yes, yeah. Again, and it's really interesting how there's an increased attention on cognitive symptoms. We're coming back to the Kraepelinian way of understanding schizophrenia. This can affect lots of different types of cognition. For example, the ability to focus, impaired attention, working memory, executive functioning, being able to sequence through tasks. It can affect speech as well in terms of verbal memory, visual memory, social cognition. So that may be the ability to essentially understand social interaction and be able to effectively interact with other people. And verbal fluency, and this can affect the ability to communicate. And as for negative symptoms, the cognitive symptoms can actually have a tremendous impact on functioning.
I believe that the theories of mind are sometimes impaired. Could you talk about that a little bit?
Yeah, so that relates, I guess, to the ability to put yourself in someone else's shoes, or the ability to think in a sort of abstract way. So sometimes someone with schizophrenia may exhibit what might be called concrete thinking, that it's a little bit difficult to try and think, from a different viewpoint, as it were.
Why don't we move on to the age of onset, the course of illness over the lifespan, and maybe how symptoms change or don't change over the course of illness?
Yes, yeah. So, first of all, we could start by talking in terms of the onset, the prevalence, and just under 1% of people may develop an episode of schizophrenia during their lifetime. Of course, that varies depending in terms of risk factors. And the peak age of onset is usually late adolescence or early adulthood. It's sometimes a little bit earlier for men than women. And also there is a slight difference in terms of incidence between men and women. The incidence is slightly higher among men than for women. Having said that, schizophrenia can develop earlier in life, early onset schizophrenia in childhood or early adolescence, and even in later life, in older adults with late onset schizophrenia. But typically we see it in late adolescence and early adulthood. In terms of the course of illness in schizophrenia, the onset can vary in terms of the speed. And often an individual may experience what's known as a prodrome, a period of time before they first experience a psychotic episode. This period typically lasts a few months. Sometimes it can be quicker, a few weeks, or even several years. But it's usually characterized by a decline in functioning, and that may be associated with some attenuated psychotic symptoms. So maybe some unusual thoughts or changes in perception, but not to the point of experiencing frank delusions or hallucinations. There may also be changes in social interaction, a decline in cognition, and, for example, an individual might be in education, in college, or at work, and they may find it difficult to perform in their studies or their work. And then this can lead to the first episode of schizophrenia, and the diagnostic criteria essentially require the intensity of the symptoms to be such that they affect functioning, at least 2 types of psychotic symptom, and lasting at least a month continuously, but with some evidence of symptoms in the 6 months leading up to that point. And that these are not associated with another type of mental disorder, such as a mood disorder, or solely attributable to substance use or some other organic brain disorder. And in terms of the course of illness, the first thing to say is that we do have effective treatments, and most people who get treatment will have an improvement in their symptoms. And we think maybe around a third of individuals with schizophrenia who get adequate treatment, continue their treatment, may not experience further episodes of illness. They may experience remission and they can stay well. there may be a third of patients who do experience symptomatic improvement, but may be at risk of relapse and may experience symptoms again at a later stage. And then there's perhaps around 30% of patients who may experience continued symptoms, perhaps some partial improvement with treatment, or perhaps not that much improvement with the first-line treatment. And this might be considered to be treatment-resistant schizophrenia. And the course of illness can vary throughout the lifespan. So although the initial course may take some time over a few months or years, it isn't really possible to predict the longer-term outcomes. And it is certainly possible for an individual to be in remission for a protracted period of time. What I would say, however, is that the current treatments are very good at helping reduce the impact of positive symptoms. Sometimes the negative and cognitive symptoms may persist in sort of residual symptoms in between episodes of the positive symptoms.
What about schizophrenia and heritability and familial type cases?
Yes, yeah. So, I mean, there is certainly a strong genetic component involved in the etiology of schizophrenia. Also environmental risk factors, which maybe we could touch on a little bit later as well. In terms of heritability, looking at studies examining the incidence of schizophrenia in monozygotic twins, we see rates of potentially up to 50%, and in first-degree relatives, maybe up to 10%. So their heritability estimates may be looking around 60 to 80%, and that's the degree to which the etiology may be related to genetic factors. Early research into potential genetic factors focused on individual genes, specific alleles, but more recent research suggests that things are a little bit more complex, and it's thought that it isn't necessarily related to single genes, but actually several genes, and that there's a polygenic risk score that can be estimated. And if you look at genome-wide association studies, we find when you investigate large populations that there are potentially linkages to genes involved in neuronal function, synaptic architecture. And this would make sense based on the biological data we have in terms of how brain structure and functioning can change in people who are developing schizophrenia and once they have chronic schizophrenia. There's also some evidence that there may be associations with immunological factors. And this is very intriguing. It suggests that maybe there is a role for inflammation in the etiology of schizophrenia. And potentially, as we better understand these factors, this may open up new avenues into diagnosis and treatments as well. Now that's a summary of some of the genetic factors and heritability. But of course, there are other factors involved, environmental factors. And we know from large-scale population studies in multiple countries across the world that there are several environmental factors affecting individuals throughout the course of their life, in their childhood and then adolescence and early adulthood, that are associated with the onset of schizophrenia. These are factors such as, for example, living in an urban environment, and we don't exactly know why there is this association. Some research suggests it may be related to migration, or social deprivation. But the other possibility is that this could be a consequence of the illness, and perhaps actually people living with schizophrenia tend to migrate to more urbanized areas for various reasons. Other factors may include obstetric complications or maternal infections, childhood adversity. Interestingly, there is some evidence of associations with seasonality of birth, comparing winter versus spring or summer births. Perhaps that may be related to infections, exposure to infections. There's a possibility this may be related to vitamin D, which may change in terms of exposure in summer versus winter. We don't fully understand. And finally, an important factor which we're beginning to see is associated with the onset of schizophrenia is exposure to substance use, particularly cannabis or marijuana. And now we have evidence of prospective studies of individuals without schizophrenia and following up cohorts, which suggest that exposure to cannabis can be associated with an increased risk of developing schizophrenia. So taken together, really, we see a combination of genetic and environmental factors at play. And for an individual living with schizophrenia, we cannot say exactly what are the factors affecting that particular individual, but we know that maybe at a population level, these factors can interact with each other during the process of brain development. And it may be that this affects the brain development in childhood, adolescence, early adulthood, for example, affecting synaptic architecture, functioning of neurotransmitter circuits in the brain. And we have evidence of this from imaging studies, some of the earliest studies which demonstrated enlarged ventricular size, looking at CT scans in individuals with schizophrenia. Those original studies were performed in people who had been treated, and so there was some question about whether the treatment may be involved. But we now have studies following up patients who are at risk of schizophrenia and develop schizophrenia, longitudinal studies, which suggest that actually that there are potentially changes in the structure or function of the brain or connectivity in terms of the circuits within the brain using structural or functional connectivity imaging.
I believe neuronal migration has been implicated.
Yeah, that's right. So essentially, the processes by which synapses develop, and there is a process during adolescence, early adulthood, where the architecture, synaptic architecture, changes. It becomes more refined, and that's based on exposure to the world around us, synaptic pruning. So the number of synapses reduces, and this is completely normal. This is how the brain develops. And we think perhaps that there is something about this process which may somehow be affected by the genetic factors and the environmental factors.
Thank you, Dr. Patel. Maybe we can move on to treatment and maybe start with the historical or typical antipsychotic class and their benefits and their side effect burden.
Yes, yeah. So, antipsychotic treatment really has transformed the care of people with schizophrenia. And back in the 1950s, the dopamine receptor 2 blockers were developed. And so the D2 receptor, we know, is implicated in schizophrenia. We see differences in the activity in people with schizophrenia compared to individuals who don't. And so these medications are antagonists. They bind the receptor, and they are effective at reducing some of the positive symptoms of schizophrenia. Now, dopaminergic transmission in the brain, there are several different pathways in the brain, and one of the other aspects of blocking D2 receptors is it can affect movement. We know that the nigrostriatal pathway dopamine receptors, if they're also blocked, an individual can experience extrapyramidal side effects, and that can sometimes be related to first-generation antipsychotic treatment.
How about the atypical antipsychotics that have come into vogue over the last 20 to 30 years?
Yes, so this, I guess, is the next generation, the second-generation atypical antipsychotic treatments developed in the last, 2 to 3 decades. And like the first-generation antipsychotics, they also are dopamine 2 receptor antagonists. But within this class of medication, atypical antipsychotics may also have activity at other receptors or neurotransmitter pathways, such as serotonin. And so they still have the effectiveness in terms of reducing positive symptoms, but may have other effects as well. And these vary depending on the type of second generation antipsychotic. But the potential benefit may be a difference in terms of improved tolerability with respect to some of the movement side effects, which may have occurred in individuals with the first generation antipsychotics.
What about promising new treatments, such as the muscarinic agonist, the glycine inhibitors, etc.?
Yeah, well, I mean, it now is a very exciting time, and I think that in the last 5 years or so, there's been tremendous promise in terms of novel targets in schizophrenia. So the muscarinic receptor agonists are one example of this, and so these potential treatments may help to regulate the activity of dopaminergic neurons. So this is still a medication that may target the same kind of neural circuit in the brain, but rather than targeting the receptor postsynaptically, these medications may modulate presynaptically the release of dopamine. And so this opens up a novel therapeutic avenue that may provide, I guess, a more fine-tuned approach to regulating dopaminergic transmission. Some of the other potential new pharmaceutical treatments include voltage-gated sodium channel blockers. These may potentially modulate the activity of the glutamate pathway. So this is something we haven't talked about yet, but the NMDA receptor and the glutamate pathway may be implicated in schizophrenia with evidence from functional imaging, PET imaging studies, particularly for some of the negative symptoms or cognitive symptoms. So this opens up a very exciting avenue to consider other therapeutic targets that could not only help with the positive symptoms, but also the negative and the cognitive symptoms. The other thing is the antipsychotic medications continue to be further refined and developed, and there are more recent preparations. One might class them as a sort of third generation antipsychotics. Some of them are partial agonists at the D2 receptor. This just helps widen the therapeutic repertoire. The other thing about the antipsychotics is the mode of delivery. So originally antipsychotics were available either in oral preparation or maybe a short-acting injectable preparation. And more recently, we've had access to longer-acting injectables. So an individual who may be at risk of relapse may benefit from a longer-acting or long-acting injectable antipsychotic. And more recently, preparations have been developed that have an increasingly longer duration of action. So originally, maybe it would have been a week or 2 weeks. Now we're looking at potentially 1 month, 2 months, 3 months, even 6 months. This potentially will help a great deal to ensure that an individual with schizophrenia is able to get consistent treatment, because we know that medication interruption or cessation is a strong risk factor for relapse.
Non-compliance. It's such a big part of relapse.
Yes, yeah, and it can be very, very difficult, and that there are various different reasons for that, and that may be related to sometimes balancing the beneficial effects of the antipsychotic with the adverse effects, but also being able to have preparations which help promote adherence and ensure someone has a consistent level, therapeutic level in the plasma. So that's some examples of some of the novel pharmacological treatments. We could also talk about some of the non-pharmacological treatments.
Please do.
Yeah.
Non-pharmaceutical interventions are a part of the therapeutic plan for schizophrenia.
Yeah, absolutely. And this is very important, I think, for someone living with schizophrenia, as we talked about. antipsychotic therapy has really transformed the treatment, but it is only one part of the care package for someone with schizophrenia. Other potential modes of care include psychological therapies, for example, cognitive behavioral therapy for psychosis. And cognitive behavioral therapy is a type of talking therapy, and in the context of schizophrenia, CBT for psychosis can be very helpful for an individual to manage positive symptoms, for example, auditory hallucinations, hearing voices, which potentially could be very distressing. And actually, the CBT can help an individual to manage those experiences. And of course, antipsychotic medication will help with that as well. But to reduce the level of distress, maybe help someone to not have their life so interfered by experiencing auditory hallucinations. Other types of psychological treatment that are helpful include family therapy. We know that an individual living with schizophrenia, the people around them, the environment they're in is so important in terms of their well-being, in terms of promoting recovery, promoting remission and recovery. And so family therapy can be particularly helpful. The other aspect is social care and social support. So initiatives to support community mental health care, supported accommodation. We were talking earlier about how sometimes the cognitive symptoms and the cognitive decline during the prodrome can make it difficult for someone living with schizophrenia to be in education or work. So sometimes occupational therapy or employment support can be very helpful. And I really want to give the message that you can work, you can go to college, you can do all of these things if you're living with schizophrenia. And it's very important to have that as a goal and to have be able to have meaningful and purposeful activities can be very helpful to maintain good quality of life. And so we talked also a bit earlier about how antipsychotic treatments are very effective for positive symptoms. There are also potentially new treatments that may help with some of the negative and cognitive symptoms, which are also a core feature of the disorder. One of the things that I think is important to realize is that although an individual with schizophrenia may come to the attention to healthcare services with positive symptoms, and that may be the thing that is really causing difficulty at the time when they're first experiencing a psychotic episode, negative symptoms and cognitive symptoms are a core feature of schizophrenia. And historically, there have not been many targeted therapeutic options for these sorts of symptoms, for negative and cognitive symptoms. Having said that, there are some treatments available. So for cognitive symptoms, cognitive remediation therapy, a type of talking therapy, can be very helpful. And this, again, may help improve someone's functioning. Cognitive symptoms can have a significant impact on functioning. There's also huge promise and potential with digital therapeutics. So this might be, for example, a smartphone app that may include cognitive tasks that could essentially help to improve someone's cognitive functioning using a particular task on an app, and then that may then help them apply, that improved cognitive functioning in the activities that in their life. We mentioned earlier about the glutamate pathway, and that there is the potential for modulators of the NMDA receptor, GlyT1 inhibitors that may be able to help address some of the cognitive symptoms. There is also some evidence in some of the newer so-called third-generation antipsychotics that they may have some degree of benefit for negative symptoms, potentially also for cognitive symptoms. But we need some more research to better understand this. And as well as considering pharmacological treatments, as we were talking about before, thinking about psychosocial interventions. Now that we understand better the potential impact of negative and cognitive symptoms, I think being able to identify where these are problematic and then being able to then offer treatments that are of benefit, I think is going to be very important going forwards.
Maybe we could turn now to your research and what you do for research, and we would find that very interesting.
Yes, so I am by background a general adult psychiatrist, so I look after people who are adults between the ages of 16 and 65 with mental disorders, including people with schizophrenia, and so a lot of my work has involved looking after people who are at clinical high risk. So this is before an individual develops their first episode of schizophrenia, after they develop their first episode, and then if they have then developed chronic schizophrenia. And my background is in healthcare data analytics. So what I do is I analyze large population data sets and large healthcare data sets. And here in South London, we're very fortunate to have access to a de-identified case register, which is derived from electronic medical records of people receiving mental health care in South London. This data set goes all the way back to 2007, and we have data on maybe over 400,000 patients, and of these, we have potentially around 20 to 30,000 patients with schizophrenia. And I have assembled some of these data to ask research questions that really speak to the unmet need of individuals living with schizophrenia. And I would say, the principal unmet need, even before we talk about treatments, is detection, the identification, and actually the delay in a diagnosis. And we know that sometimes people can be waiting some time before they access some sort of assessment and can get a diagnosis. And that period of time, known as the duration of untreated psychosis, we know that if we're able to reduce that, that may help to improve clinical outcomes, because we get someone engaged with treatment earlier on, then perhaps when they are in education or in work, and they're able to continue doing that. And there is the potential for developing tools that can mine the electronic health record data and artificial intelligence prediction tools to look at the patterns of data to actually predict the risk of developing a psychotic episode. And this may help us to identify people earlier on who may be at risk, and then provide early intervention earlier in the treatment pathway. Then the next side of it is for people who have developed the disorder and may have experienced their first episode, or are experiencing periods of relapse. Again, looking at the factors related to relapse. So I've conducted research demonstrating that we talked earlier about cannabis and the potential role in the onset of schizophrenia. I also looked in a cohort around 2,000 patients at the risk of relapse, and found that cannabis use has a significant association with increased risk of relapse among individuals with first episode schizophrenia.
In your opinion, is that an unmasking or a causative agent?
Yes, we don't know. We don't know. I mean, the other potential possibility, we don't know that the cause, there may be that it's contributes to the onset of schizophrenia. By the same virtue, it could be that people may use cannabis to try and help with some of the symptoms of schizophrenia. And this is very interesting because, actually we didn't talk about this earlier, but another potential therapeutic avenue is cannabidiol, the CBD, which is currently being investigated as potential treatment for psychotic symptoms. So very interesting. We'd have to tease this apart further. So yes, so that's is some of the studies looking at the sort of risk factors for relapse, and then some of the work I've done looking at treatments, for example, the associations of different treatments and clinical outcomes.
Thank you, Dr. Patel, for presenting your research. It's very interesting and is undoubtedly contributing to better treatment of schizophrenia in the world today.
Well, thank you so much. It's been wonderful to join you for this fireside chat on schizophrenia. And I guess the last thing to say is just how exciting it is at the moment in schizophrenia research. Several new therapeutic options which may be available on the horizon. And I guess if I have one message for people who may be living with schizophrenia or people who may be caring for someone with schizophrenia, it's that I hope there will potentially be many more therapeutic options available. It's a very exciting and hopeful time in the world of schizophrenia research and treatment development. Thank you.